Welcome, everybody. Welcome to another episode of PEM Rules, the Pediatric Emergency Medicine podcast. I'm your host, Yaron Ivan, as usual, and today I'd like to talk about a very important topic. This is something I do in the Pediatric Emergency Department on a daily basis. Pain control. Sometimes chronic pain, sometimes acute pain, and many times it's a very frustrating experience. Having an innocent child with an injury or a chronic disease that you try to do the best and alleviate the pain to the best you can, but you're not successful, can be a very frustrating and difficult experience. This is why I invited a pediatric anesthesiologist who happens to be a pain expert all the way from the Children's Hospital of Colorado to talk to me about how to better treat pain in children. So, thank you, Alan, very, very much for coming on the show. I know for a fact that you're a busy guy, and I appreciate your time. Let me just introduce you to the listeners, and then we can get started. Alan is originally from Charleston, South Carolina. Went to medical school at Emory University School of Medicine, finishing in 2004. He then did his general anesthesiology residency in Chicago at McGaw Medical Center, which is Northwestern University, finishing in 2008. And then did his fellowship at the Children's Memorial Hospital, graduating in 2009. Currently, Alan serves as the Director of Pain Services, which is perfect role for the topic we're going to discuss today. He is the co-director of the wellness program, and he's also the team captain for the charity cycling team. Is that all correct, Alan?
That's all correct. Yeah, I think
Perfect.
honestly, one of the main roles that I have is that I'm just here a lot.
Yes, we call it our clinical commitment.
Yeah. I think that I get these names because I'm just around more than other people sometimes. And I say yes.
Welcome to the club.
Yeah.
Most importantly, that I recently heard, Alan is like me, Alan is an avid musician who practiced medicine on the side.
Yeah.
And I just learned that, like me, he started as a bass player, and now he kind of plays everything. Is that true also?
Totally true. And there's a really fine line between being a musician and a guitar collector. And I think that line gets a little bit blurry with me.
Yes, I know exactly what you're talking about. So tell me briefly, what kind of music do you like? What kind of music do you play?
Well, I really love rock and roll history. So I will move anywhere from standard Chicago 145 blues and boogie through folk to rock. And I'm currently in a little bit of a metal phase, and it just gets really difficult. We're lucky in Colorado because we have Red Rocks here and the Mission Ballroom, both they're just incredible venues. And so I'm going to see Wilco, which is probably my favorite band, in October, I believe, and really looking forward to that.
Wonderful. And second question, before we talk about the non-important things like medicine, how many guitars do you have?
It gets ugly. The question can be where. There are some hidden back in Charleston that have not been imported to Denver. Currently, the Denver stash is going to be one acoustic guitar, two acoustic basses, and then four electric basses, one of which is not functional, so it's a relic. It's a 72 SG bass. It's the L series with double humbucker SG style bass guitar. But there's some in the works. We're looking at a PRS maybe coming into the family in October or November, maybe.
Very nice.
Yeah.
Congratulations when it joins the family.
Thank you.
So let's talk about some important things, aka medicine, Alan. And I'd like to start by asking you a question I ask all my guests on PEM Rules, and that's a question that I feel is very useful for us because we work with other subspecialties. What is your definition of a good PEM physician? Someone who does what?
A collaborator. And I have a massive respect for our PEM colleagues, and I actually know a fair amount of them. I believe that a hospital structure thrives with teamwork that goes across the venues and de-silos. And I know that's a lot of yoga babble, but it's really true. We have an emergency room, we have the wards, we have operating rooms, And if these operate as a silo, the communication just becomes one-upsmanship. And with our PEM docs, I think that they're incredible because they have to think a couple of steps ahead of everything. It's like a 3-neuron connection. So a great example for us is a chronic pain patient presenting with worsening pain that's typical for them. And it would be easy enough just to say, okay, whatever, admit them and let the peds team figure it out. But that may not actually be the best thing for the patient. It's about the extra mile. And that happens when they reach out to us, chronic pain doctors, and see, okay, what are the specific concerns? What are the interventions that we should try before admission? And, from my acute pain side, talking about regional anesthesia, saying, hey, either we can do a block or can you come down and maybe do a block? Those are all things that when you collaborate together, you can make a pretty seamless transition from the emergency department theater to either home or the proper place in the hospital. And I think it really cuts down on a lot of the siloism that you say, okay, I think it's this, put them up on the floor. And the floor says, well, we don't think it's that. And that just creates havoc and parents get frustrated. So I think collaboration, and the long answer, being told collaboration is the short answer. And yeah.
Yeah, so that's a great answer. Certainly something that us PEM clinicians strive for, and I totally agree with you. You also mentioned something very interesting and very important. That's actually one of my rules. A good ER doctor is always a step ahead. Yeah. Unfortunately, when I resuscitate a child and I order a dose of epi, I always order another dose to be obtained but not given. So I try to be a step ahead, like you mentioned. So thank you very much for that answer.
Yeah.
My next question to you, Alan, and again, as a pediatric anesthesiologist and a pain expert, that's something that I think us PEM physicians deal with all the time.
Yep.
I use narcotics and benzodiazepines in my work all the time for anxiolysis, for pain control. We see a lot of patients with sickle cell disease, unfortunately. And I think us non-anesthesiologists always worry about overdosing a child on benzodiazepine and or narcotics and causing respiratory arrest or bradyapnea or some other respiratory related complications. So I'd love to hear from you. How do you go about this? I was once told by an anesthesiologist that as long as the patient is still experiencing pain, you are far, far from respiratory arrest or respiratory depression. What's your opinion about that?
Sure. So there are a couple different kinds of pain, and I think that that's consideration one. Acute pain is our natural somatic or visceral pain that you're going to get from an injury, or even neuropathic pain, which takes a little more to develop, but we're going to leave that out of a category of what we're going to talk about. So acute versus chronic pain. Let's talk about acute pain, which is probably the bulk of what you're going to see in the emergency department. There are truths and there are handed down knowledge, and there are things that might not be right, but I'll tell you what I know. I know for sure that benzodiazepines and opioids are synergistic when it comes to sedation and respiratory depression. That's one thing I know. I also know that opioids specifically are very effective. And there is some information out there that looks at outcomes. And I think that when they say that, NSAIDs and acetaminophen are as effective, I think that that's an overgeneralized statement. Opioids work. The problem that we run into is when they're too effective, right? And you get sedated, or you're hypopnic, or you become hypercarbemic. So always, the first thing I think it's good to say is, what are we treating? Okay. So if you're treating acute pain, I think it's okay to use opioids if they're what you think you need, as long as they're included with a multimodal technique. And the multimodal technique, our multimodal approach is using different classes of medicines and using smaller amounts to decrease side effects. and increased our synergy with medicines. So if you're going to give opioids, you need to ask yourself, should I give acetaminophen and Toradol also? Do I need to consider a benzodiazepine if this is just anxiety? Or if there's an anxiety component, do I use a low dose of benzodiazepine? The problem is that a lot of these issues, anxiety, pain, different types of pain, can coexist a little bit. So what do? You identify host factors. Does the patient have obstructive sleep apnea or chronic pulmonary disease? Do they have renal failure? If these are present, you're going to have to use smaller doses and titrate to effect. You can also think about the onset times to guide you. A stepwise fashion could be oxycodone. So oxycodone, let's talk about it. Peak onset is in about 20 to 30 minutes. So if you give oxycodone and it's not working in 5 to 10 minutes, don't immediately jump to use a high-dose benzodiazepine because they're going to meet their peak action around the same time. Think about it as a multimodal approach. Use a reduced dose of the benzodiazepine if you're going to, and then keep an eye on them. The classic teaching that you alluded to of pain is a natural naloxone, I think it's partially true. It has been explained to me how it works. I've noticed that in general, yes, that's the rule when you're dealing with acute pain in patient that is not opioid sensitized, if that makes sense. If you're using opioids alone, I think it's true. I think when you start clouding the picture with benzodiazepines and other sedating medicines, you might not be able to use that rule as much. Let's talk about fentanyl, okay? Fentanyl is amazing. It's hemodynamically stable. It's pretty predictable. It has a peak onset between 3 and 6 minutes. As a pain medication, though, is it the right one? Its clinical half-life is around 30 minutes. It hangs out in a subclinical fashion a little bit longer. So maybe that's not the right pain medication to use because it is sedating. So every medicine has its pluses and minuses. I think the key points with them are, yes, it's okay to use them. Identify host factors that may alter the response to them. And ask which one you're using if it's appropriate. Is this a very short-term pain that we need to get on top of quickly with a fentanyl? Or is it a more long-term pain that we should use with oxycodone? And then the final pledge I think that everyone needs to make is if we're going to use these medicines, we always have to ask ourselves, are there additional non-sedating adjuvants that we should also be using?
Can you briefly discuss that? What other adjuvants do you recommend us PEM physicians to use? I mean, when you say that, I think about distractions with child life.
Right. Yeah.
What else comes to mind?
You go all the way from the non-pharmacologic to the pharmacologic. So the non-pharmacologic are going to be child life, ice, heat. You can consider massage. You can consider TENS units sometimes. I know I personally have a TENS unit on basically every night because I have a little bit of cervical radiculitis. You can go for distraction. Emergingly, you're probably going to see a little bit more use of virtual reality because I think that can be a pretty powerful tool that we don't realize. So those are some of the non-pharmacologic techniques. On the chronic pain side, we use psychological techniques that may not be great in the emergency room. I can't say that anyone will ever be hurt by deep breathing, but it may not be as logistically valid in the ED setting. So those are the non-pharmacologic medications or treatments to consider. The pharmacologic treatments of pain, I think, fall into a couple of different classes. So opioids are obviously the first one, and those are divided into our short ones, which are going to be fentanyl, alfentanil, remifentanil, sufentanil. Our intermediates, which are the classics, those are morphine, hydromorphone, oxycodone. And then the long-term ones really are a little bit different. Those are going to be buprenorphine and its various packagings, methadone, transdermal fentanyl. I don't think those are going to have a lot of use in acute pain. So that's our one class of medicine. The next class of medicine is going to be acetaminophen, which needs to be dosed properly. The problem is when it comes in combinations with other medications, a lot of the time you probably could use more acetaminophen. And so I like splitting them out for that reason. I say optimize acetaminophen. The next class is the other anti-inflammatory nonsteroidal, although that's what a nonsteroidal is, I guess, nonsteroidal anti-inflammatory medication. So ibuprofen, ketorolac, anything in that class, really. I don't have a strong opinion of one versus the other. The nice thing about IV ketorolac, and to be honest with you, IV acetaminophen, is that you get a nice effective blood level sort of right away and quickly, as opposed to needing a couple of doses orally. The next class medicines that we use, obviously sparingly, are benzodiazepines, and because we use those for both anxiety and muscle spasm, although we fully realize that they can have a synergistic effect with our opioids and can make it sedating. Other medicines to consider could be tramadol. So where does tramadol fit, right? Well, tramadol is an opioid, so it has mu receptor agonism, but it also has some selective norepinephrine reuptake inhibition and can be somewhat effective in more of the neuropathic or neuritic style pains. It also can have some use in our chronic kids. It can be a good rescue treatment for chronic kids. I don't love for them to be on it all the time because I don't like for chronic kids to always to be on opioids as rescue, but it's a good one to have in your back pocket. The next class of medicines you can consider are going to be our alpha-2 agonists, and that's clonidine. It can be a little bit sedating. Dexmedetomidine can be very sedating, but at low doses can have a little bit of an analgesic effect. And we often use a medicine, tizanidine, which has alpha-2 agonism as its mechanism. We use that for muscle spasm, and I would say a lot of us are using it as our antispasmodic of choice rather than a benzodiazepine. It can be a little bit sedating, but it can be very effective. Other classes of medications to consider are some of the non-sedating muscle relaxants, which are metaxalone, and you can use Flexeril or I think it's carbamazole. Those can be really pretty useful. We have very limited use of cannabinoids, even in the state of Colorado. We don't really use those in the acute pain setting. Those don't tend to be very useful. There's one medication that I think really is probably a little bit underutilized in the pain setting acutely, and that's ketamine. So ketamine is interesting because it has a wide dosing regimen with different effects. So below 0.3 milligrams per kilo, you really have an analgesic effect. And, it tends to be, we run kids on infusions with this a lot, and it's very effective. It's opioid sparing. It has very few side effects. Once you go to about 0.8 to 1 milligram per kilo, it tends to be a little bit more of a sedative. And then when you're using military dosing, like we do sometimes in anesthesia, that's 3 to 5 milligrams, and that's an anesthetic. So the side effects of those are pretty well tolerated. It's an NMDA receptor antagonist. There are other NMDA receptor antagonists out there. I think they have relatively limited use. That's magnesium as IV infusion. And interestingly, dextromethorphan also has some, but that you see that more in the chronic pain side. So those are the bulk of the medications that we run into from an acute consideration. And then you have regional anesthesia. So that can go anywhere from a lidoderm patch, which is what we call a poor man's regional block, to an actual indwelling nerve catheter that can be placed.
Very good. So you clearly are extremely knowledgeable in the field of pain control. That's fantastic. And I think that was really good overview. A lot of what I at least don't know. I want to reiterate one thing that you said. I'm actually very happy you said that because we as PEM clinicians and PEM physicians, I personally love ketamine. I do a lot of sedations in the ER, mostly for fracture reductions and pain control, but I don't think I personally don't use ketamine as an analgesic, as a sole analgesic. So I just want to reiterate one thing you said. So you're saying that ketamine at the dose of 0.3 mg per kg, safe, effective analgesic, and I don't
Yeah.
need to call the sedation team or anything like that, correct?
Yeah, I think that, we have kids on the floor all the time that are run on infusions at 0.3 milligrams per kilogram per hour. So I think it's reasonable depending on the bylaws of the hospital. I would
Sure.
also use it really in cooperation with the sedation committee, those kind of things. But it's underutilized. I made one mistake. I called Flexeril methocarbamol. It's cyclobenzaprine.
Okay.
So yeah, yeah,
Thank you for the correction.
yeah,
My next question to you, Alan, and again, this is taking advantage of your expertise. Us PEM clinicians and PEM physicians, I think we're pretty good in dealing with the acute abdominal pain. I know a lot about appendicitis and the most common cause of acute abdominal pain based on age,
mhm,
acute respiratory complaints, etc. But being PEM clinicians, we're not that good about the chronic stuff. What will be your best advice for us to deal with those patients that we often see with chronic pain?
sure. So chronic pain is a different beast. It has its risk factors. It has its own pathophysiology. And I think understanding that it is a biopsychosocial syndrome is really important. And I don't do that to say that the folks aren't suffering. I do it to say that it doesn't obey by rules that we're used to playing with. So, the first thing I would say, obviously, biopsychosocial, and it doesn't mean that it's all in your head. It means that what's in your head is having a significant impact on how your body processes pain. You can almost think of it like a seizure disorder that sits there, and usually you can take care of it, but sometimes it gets worse, and it can be affected by stress, weather, biologic considerations, all of these things. So I think that's really important to point out, and it's also important to listen to the patient. Um, I think pain patients carry a lot of baggage because a lot of them have been told that the pain is in their head. And the joke is that of course it's in their head. That's where pain's processed. So it all comes from there. So chronic pain really develops in an insidious nature in kiddos that may be susceptible, and we don't totally know why. So the first thing to do is listen to the patient. Also, it's very important to go ahead and ask them what's worked and what hasn't worked. But I think it's also important not to reinvent the wheel. I don't think I've ever heard of a chronic pain patient's pain being fixed in the emergency room acutely. It just doesn't work like that. And so we run into problems where we have kids that have been treated for a while by our chronic pain docs, and they come in and instantly they say, okay, new plan, here's what we're going to do. I think the key thing is to identify their caregivers for the chronic pain side, figure out what works for them. Don't ignore them. Make sure they're not having a new medical emergency, right? Like you can have chronic pain and still have appendicitis, but really get an idea of what's worked and try not to reinvent the wheel. And unfortunately, when we deal with them, I think it's important to understand a couple of things. The first thing is it's not going to get better quickly. They have neuroplasticity that has changed. It's going to take a while for it to get better. And if they break a bone, guess what? It's still going to take a while for them to hurt less than maybe some of their cohort. The second thing is that their pain scores might not improve as quickly as we want them to, but that doesn't mean that we don't treat them. So I'm not saying have lower expectations, just realize, hey, this might take a little bit longer to get better. Sometimes they do need to come in house when you would think that they could probably go home. They just act a little bit differently. With a lot of our kiddos, if something bad happens to them, you'll see us put them on a low dose ketamine infusion a lot quicker than people might think. But that's just to try to decrease the amount of recruitment in the spinothalamic tract that they can have with their altered neuroplasticity. So we tend to be a little bit aggressive with them. Another key point is that when you're taking care of any kid, obviously, if you decrease the amount of acute pain that they have, you will decrease the risk of development into chronic pain. Okay. But when you take care of a chronic pain kid and you're doing something that's acutely painful, you may have to increase your modalities that you use so that you don't run into a pain crisis.
Very good. This is so again, very, very valuable information for us PEM clinicians. Thank you for all that. And I think again, you alluded to one of my rules that I talk to the residents about all the time. When you speak to the parents, when you speak to the patient, set up the expectations.
Yeah.
I think if a kid with sickle cell disease with chronic pain is coming to the ER today, I can certainly help. But I often find myself saying, Mom and Dad, just so you know, I don't think we'll be getting to zero pain today, but we're certainly going to try. So setting up the expectations, I think, goes a long way.
Yeah, absolutely. And the communication with them that, yeah, you are experiencing pain. I would never say that you're not experiencing pain, discomfort. We're talking about what we can control, what we can't control, and what's safe.
Perfect. Exactly. So, Ellen, thank you very, very much for coming on the show. This was an extremely beneficial information for us. As usual, I'd like to dedicate the outro of the episode to the guest. So that'll be you today.
Thank you.
Usually I have the guest pick a song, but I have a feeling, being a bass player, that you like Red Hot Chili Peppers.
Absolutely.
Perfect.
Flea, you got to read the biography. It teaches a lot about what it is to be a teenager. I think it's really important.
All right, very good. So I'm going to play, in honor of you coming on the show, Fortune Faded by Red Hot Chili Peppers. It's a great bass line. It's a great guitar line also.
Great honor. Thank you.
Thank you. So thanks again for coming on the show. And hopefully when you come to Vegas one day, we can jam.
Absolutely.
Wonderful. Thanks again, Ellen. Have a great day.
All right.
And that is it for today, guys. Thank you very much for listening. I hope you learned a lot from Ellen and pain control in pediatric patients. I hope you like the Red Hot Chili Peppers and the outro. Please continue to listen to PEM Rules. Send me any emails or any feedback you have. I always love hearing from you guys. This is Fortune Faded by Red Hot Chili Peppers. Hope you like it. Thanks for listening.